Hey, this is Dr. Angela. Welcome to another special Soundbite episode with the Lifestyle MD. I am going to share with you something that I am super excited about, and that is the updated cholesterol guidelines. Yeah, I know, cholesterol. Who gets excited about that? A primary care doctor does. And the reason I am excited about that is because it is introducing a more nuanced approach on how to prevent and risk stratify your patients and determine who actually would benefit from statin use, who benefits from aggressive lifestyle interventions. It goes beyond just looking at your bad cholesterol, the LDL. It goes beyond just looking at your total cholesterol, which we haven't done in a very long time. So I'm just going to try to talk about this in a way that most people who aren't in the medical profession will understand. The first thing I'm going to tell you about is everyone is now recommended to have a Lp(a) or lipoprotein A checked at least once in their lifetime. Why does this matter? This is something that I have been doing in my practice now for the last 2 years. The Lp(a) predicts your genetic risk, regardless of your lifestyle, regardless specifically about whether or not you're eating healthy, whether or not you are avoiding toxic substances, smoking, drinking, things that can increase your cholesterol numbers. This number is independent of that. So this is especially relevant to people who may have a family history of strokes or heart attacks really young in life. And this is going to help you pick up on people who have what looks like normal labs, but have a genetic risk that they need to address. And this is something that you're just going to have to be really aggressive about with medications. Truly, I don't know what percentage of people this covers, but it's really important if you haven't had one checked, and especially for someone who has a family history, that you should be looking at this Lp(a). And an important thing for patients to understand is that this number doesn't normally change very much. Rechecking it every year, every other year, or doing lifestyle interventions, it's not going to be any major benefit. We're really just trying to catch early on if you're someone who represents a high-risk population that we need to pool or evaluate separately. And then, quite frankly, recommend that you go on a statin. The next big change or pivot in the guidelines is recommending testing for Apo B. This is huge. So the guidelines fall short of recommending it for everyone, but do recommend that you consider in people who you might suspect have a higher risk. People with high triglycerides, people who have insulin resistance or type 2 diabetes, people with metabolic syndrome, or maybe even people who have significant family history of predisposition to coronary artery disease, but for whom the Lp(a) is actually normal. What is significant about Apolipoprotein B? Well, it more precisely measures your atherosclerotic risk. It looks in fine detail. So LDL, these are like small particles. We call them the bad cholesterol. LDL tells you the mass of the cholesterol that you have. The Apo B tells you how many of these particles you have. So think of it in these terms. Mini Coopers are really small vehicles, right? And Escalades are really large vehicles. Mini Coopers and Escalades all have an Apo B on them. They all have one. But who takes up more space on the road? The Escalades. So you could have a highway full of Escalades, and it's going to have the same density or LDL number than a highway full of Mini Coopers. But they all are carrying one Apo B. The highway that has the Mini Coopers on it is going to have way more Apo B traveling than the highway that's full of Escalade. So translate that into real human cardiovascular risk terms. The smaller your particles are, the more risk they are to you and your body. So the more these little tiny particles carrying a single Apo B are, the more opportunities there are for cholesterol to clog your arteries or for calcification to occur down the road. I hope that kind of makes a little bit of sense. If it doesn't, suffice to say, Apo B is more precise, and it's worth knowing your Apo B number, because if it is high, irrespective of your LDL, you're at higher risk, period. The other addition to the guidelines is coronary calcium scoring. So coronary calcium score has been something that we have used selectively in medicine for some time. It was previously had a class 2B recommendation and is now moved to a class 1 recommendation, which is like the highest evidence of its benefit. It is still only recommended to use it in people who are borderline or intermediate risk. I'll explain to you how to assess that next. But if you're not quite sure if you're someone who would benefit from starting a statin or cholesterol-lowering medication, then you're going to be a good candidate for this if you kind of fall in the gray area. Or if you're someone who's like, I don't really want to take a statin, I need to know more objectively if it's something that I need to do, this is a good test for you. What it does is it actually measures the amount of calcification that is in your arteries already. You can actually reverse coronary disease with a plant-based diet. Maybe I'll talk about that in another episode, but let's just be real. It's hard to do. If it was easy, then we wouldn't have any coronary disease, right? So if you're hesitant and you're not sure if taking a statin is the right thing for you, get in a coronary calcium score to see your plaque burden in your arteries can help definitively make that decision for you, or help you make that decision. It is most useful in men who are over 40 and women who are over the age of 45. Consider it the tiebreaker test. Another piece of information, the primary prevention goal for patients is to have an LDL that is less than 100. Higher risk patients should have an LDL less than 70, and very high risk patients should have an LDL less than 55. If you're not sure which category you fall into, it's important that you talk to your primary care doctor about it. What I was alluding to earlier about establishing whether or not you're low risk, borderline risk, intermediate risk, or high risk, that comes from the new risk calculator called Prevent. We have been using something called the ASCVD risk calculator for quite some time. That was an older calculator that used pooled cohort equations, and it tended to overestimate risk and overestimate the need to use statins by as much as 40 to 50%. This new calculator, not only is it more precise, it expands the age. It used to be for ages 40 to 79. Now it is applicable to ages 30 to 79. It gives you both a 10-year risk and a 30-year risk. And it includes more factors in determining what that risk is, such as BMI, your average blood sugar known as the A1C, your kidney function, and zip code. Instead of looking at race, it's looking at social determinants. Now, how it gathers that from zip code, or what details it's looking at with regards to the zip code, I'm not sure, but I can really appreciate that it's taken into consideration that factors like, hopefully factors we call social determinants of health, which is relevant. So it is a much more realistic, in my opinion, much more comprehensive picture of someone's actual risk than just looking at the cholesterol numbers alone. So super duper great. I'm really super duper excited about this. It is a major pivot and a step in the right direction. The categories that come out of this when your risk is calculated are going to be low, less than 3%, borderline 3 to 5%, intermediate 5 to 10%, and high, greater than 10%. I plugged in my information to calculate my risk. I just got my cholesterol numbers done, and my risk is less than 3%, despite the fact that, believe it or not, I have an LDL of 161. I have had a high LDL for many years. My HDL is 73. That's actually the lowest it's been in a number of years. It's normally above 80. And that's actually something I've been able to improve with lifestyle modification over the last decade. So it's interesting when you take in consideration all of the factors. Despite my LDL being relatively high, my overall risk is still less than 3%. That doesn't mean I'm going to ignore it. So really relevant. I like how this new calculator works. Key takeaways. What this means in real life. Every adult should have their LP little a checked at least once. Apo B should be checked in any patient who has metabolic risk factors: overweight, obese, type 2 diabetes, kidney disease, insulin resistance, metabolic disease. You should have your Apo B checked. Coronary calcium score, useful when the doctor or the patient is on the fence about treatment. Really awesome, again, is that we're thinking beyond just LDL alone. We're looking at the whole metabolic picture of the patient. My biggest takeaway from this is that we're finally moving more towards precision prevention, not just treating numbers. We're trying to understand what is behind someone's risk. It's much more nuanced. This is a direction that medicine needs to go, and it has now made it into guidelines. And honestly, this aligns much better with how I already practice, and I'm really excited to see that this is moving into mainstream primary care. All right, take care, guys. Have a good one.